Hello everyone, welcome back to my channel. So today I have a cytology that is taken from a tumor, cutaneous tumor from a 7-year-old Rottweiler, and the location of the tumor was in the right forelimb area towards the distal extremity, and the tumor was subcutaneous and it was darker in color, so they were suspecting it could be melanoma. So cytologically also it looks a lot like melanoma. I'll show you how. So if you see this slide here, the cells are cohesive and the cells have variable nuclear cytoplasmic ratio. So you can see this cell here has intermediate nuclear cytoplasmic ratio, but cells here pretty much looks like they have high nuclear cytoplasmic ratio, and overall all cells have marked anisocytosis. All the cells show marked anisocytosis and marked anisokaryosis, and the nuclear chromatin is not uniform at all. Nuclear chromatin is coarse. Some cells have compact nuclear chromatin, and they all, each and every cell has prominent nucleoli, and some cells have multiple nucleoli. Like here you see two nucleoli, and you can see here there are two nucleoli here. And with this picture we can conclude that this is a case of malignant melanoma, and the cytoplasm also has abundant melanin granules. They are green black in color. So this is highly suggestive of malignant melanoma. And we have another picture of the same cytology. The cell over here has abundant melanin granules, but not other cells. But other cells do show marked anisocytosis, variable nuclear cytoplasmic ratio, and prominent nucleoli, multiple nucleoli. So all these features supports malignant melanoma. So in general, melanoma is highly pleomorphic tumor. It can appear like a discrete round cell tumor, sometimes it can appear like epithelial tumor, and mostly it does appear like mesenchymal tumor also, because here we are able to see that some cells do appear like mesenchymal cells. And coming to the grading, and not grading exactly, benign tumors tend to appear uniform. Okay, they have minimal anisocytosis and anisokaryosis, and the mitotic index will also be really low, and benign tumors have very good prognosis. But malignant tumors like this have marked anisocytosis and anisokaryosis. The mitotic rate will be really high, and the prognosis will be really bad. And malignant melanomas commonly occur in the nail bed area, in the lip, and mucocutaneous junctions. When you see a melanoma in these regions, they are going to be highly malignant and they carry poor prognosis. And cytologically, you also need to differentiate melanoma from few things. One is hemosiderophage, because hemosiderin granules can look very similar to melanin granules, and you have to know whether it is a normal melanophage or it is a hemosiderophage, like that. So there are some stains which you can use to differentiate. For example, Prussian blue is the stain that is used to differentiate hemosiderin granules from melanin granules. And not all melanomas have granules. Okay, there is a separate category of melanoma which is called as amelanotic melanoma, where you don't see any granules at all. And amelanotic melanomas tend to appear a lot like plasmacytoma. So in order to differentiate whether it is amelanotic melanoma or plasmacytoma, you need to do immunohistochemistry and you need to use the cell marker S100 to differentiate from amelanotic melanoma and plasmacytoma. And if you suspect that this could be amelanotic melanoma, then there is another stain called Fontana stain, which will actually help you diagnose amelanotic melanoma very well than normal stains like Wright stain or Diffquick, etc. So I hope this video was useful. Thank you so much for watching.